So the next talk will be delivered by Dr. Karen Davies, who is a research fellow at Herston Infectious Disease Institute, HeIDI, and also a fellow with the Queensland Health and the University of Queensland. So Dr. Davies also works as a clinical nurse consultant on safe medication practice at the Royal Brisbane and Women's Hospital, and has a special interest in antimicrobial administration and vascular access management. Her research focuses on implementing the medication administration evaluation feedback tool she has developed as part of her PhD to support nurses in medication administration practice. Dr. Davies, welcome.
Thank you. Okay, so thanks. So my part of the talk is focusing on how do we actually deliver the antibiotics to these patients in the HITH and OPAT environment. So specifically looking at central access devices and looking at the pros and cons, but I'm not going to go into the complications because Dr. Bin is going to be talking about that. So I'll then touch on that. I think we all know what OPAT and HITH is. OPAT being when patients come into hospital, have the medication administered, and then they go home for the continuation of that, so that they're not sitting around the hospital, and it can be in a continuous environment, but doing it receiving it at home. And HITH is where the staff, the clinicians, go to the home to actually deliver that care, so the patients don't have to come into the centre. Obviously, central access device, we need to ensure that it's achievable, it's effective in a long-term therapy situation, and the idea is that it minimises that hospital stay and improves the patient experience and comfort in their own home. So just as a snapshot from our region, our health service, an example, you can see there the map of the extent of how far we go out, up to Bribie and Woodford, for those that know the area here in Brisbane. So essentially southeast Queensland is where we're looking at. The referrals, we have about 1,600 referrals with about 15,000 occasions of service, and on an average of 33 days for those patients in the HITH, in that HITH stay. And the majority of those, nearly 50%, are over 70. And some of the good things from the consumer point of view is that the treatment option of having it at home and that focus of being caring and supportive in their home environment are the key things that they feedback on. So what we're trying to achieve with these devices in that environment is that the device lasts long enough for that duration of whatever therapy that patient's receiving, and obviously minimising the complications, but also adapting to the patient's activities of daily living and fitting in with what with their life model. So there's obviously a number of different types of central devices, predominantly either anatomically located or the way it's been inserted, and they're basically I'm going to touch on and go over those today. So PICCs being peripherally inserted central catheters, the most commonly used around the place, inserted generally peripherally in the arm, upper arm, and inserted through to the heart, so it is located centrally. These are easy to insert. They can be done at the bedside. In the past they used to be done in special departments and areas set up, but now they're being done at the bedside, and we're sort of catching up with the rest of the world. I believe the rest of the world, nurses will put in the PICCs, and we're doing much more of that now than we ever used to, and there's services doing that at the bedside for the patients. It's suitable for short-term duration, so weeks to up to months, and it's less invasive than something that needs surgically implanted. The cons around that is that, there is literature to say that there's potentially higher thrombosis with PICS compared to some of the other central devices. Still the patient's got an access in their arm, so there is some mobility issues, and it still requires flushing and dressing changes, so it's for use. The tunneled catheters, they require surgical insertion, and they're tunneled under the skin, as you can see. And the intent of that is to reduce the risk of infection by, having it further away from the actual entry port from the skin. And the pros on that are that it lowers the infection risk due to that tunneling. It can be longer term, months to years, and often people like dialysis patients will have these and have them at home. And they're quite secure and durable. The risk of dislodgement and pulling and things are much lower than they are potentially with PICS or other ones. They require surgical placement, and removal, so they're not, that simple or that comfortable for that process for the patients. They and they've still got this body image thing that they've got something that's floating around if they've got that for some months, weeks or months, and that there is still some care required with that device. Implanted devices have a small reservoir under the skin, and these are often used with children and things like that as well, and cancer treatment. Because they can use it for a long time, and it's under the skin, so it's reduces. It's good for that long-term use. It doesn't have. It has a lower risk of infection, and there's not that body image component as well. So there's no external flapping around or components to that. The cons are that it does require surgical placement, and it can be painful when they're accessing it because they're accessing through the skin each time, and it's not ideal for very frequent infusions and access. The non-tunneled catheters, centrally located. That's generally what you'd be seeing: the subclavian vein or the jugular, internal jugular access. They're really more for acute, quick insertions that are required for acute situations. They're very short term. They've got they've got a high risk of infection. They're very difficult to secure a lot of the time, particularly when they're jugular, up there on the neck, trying to secure those, and the dressing devices are extremely important in ensuring that they're secure, and a lot of that area is very difficult, especially with males with facial hair and needing to shave, trying to keep that sticking can end up with dislodgement and infection risk because of the sweat and everything else under that. So not probably ideal in this environment. So the other things to consider, what's the duration of therapy for this patient? How do we decide which device is ideal for the patient that we're going to be caring for in the HITH or OPAT environment? What's their venous access been like before? Are they what we call a DIVA, difficult venous access, and therefore they've got maybe limited options on how to access that? Etc. Do they have what's their infection risk and other issues, and what are their mobility and lifestyle issues? Are they very active, and what's going to work best for them? But also the what therapy are they going to have? How frequently? Like I said, the ports may not be suitable for something that needs to be accessed quite regularly. And the types of infusions, and also the viscosity and the pH of the medication is really extremely important as well. So in a comparative table there, the PICS, as I said, can have a moderate risk, but can be used over weeks to months, and these are our most commonly used devices in the OPAT and HITH environment. Pretty much all our patients will have those. Some will have midlines now as well. in the HITH environment, not so much in the OPAT environment. The tunnel catheters, as I said, months to years, less risk, but need surgical implanting, and same with ports and non-tunneled catheters, days to weeks, and really not very limited use in this hospital home environment. One of the things that with the PIVCs and things now is that the HITH nurses are able to actually insert them in the home as well, and I'll talk a bit more about that in a sec. Some of the common complications, I'm not going to go into detail, but there are complications that Ben is going to go over, looking at infection, thrombosis, obviously the dislodgement and occlusion issues, and patient experience, but I won't touch on those too much. What we do need to do is how do we mitigate the risks with using these sorts of devices that we're trying to generally treat an infection, and we want to ensure that we're using them safely and they're not going to contribute to that infection risk for the patients, and we're going to optimize those outcomes in the best way possible. So obviously insertion requires strict in maintenance and insertion techniques, and places like we have here in Queensland Health, checklists around how to go about doing that in the safest possible way to reduce complications. Regular monitoring, so looking at things like bundles. It's not just about one component, it's about every aspect of the care and the management of those devices. And so the infection prevention strategies such as the hand hygiene, scrubbing the hub and aseptic technique, the ensuring the patency by ensuring we're flushing appropriately in a timely manner. And as I said, more and more it's really evident that dressings are really, really important to ensure that we're reducing that infection risk, but also ensuring the securement and the preventing dislodgement of those devices. Education for the patient and caregivers. Clearly, they're the people that are going to be looking after their devices when they're at home. So it's extremely important that they understand what's going on. And there was a study done in South Australia just recently, just published in January this year, and there's colleagues in Queensland that were involved in this as well. But looking at what are the supportive care needs of the patient in the home, what are the key things that they need. And if you're not familiar with AVATAR, it's the Alliance for Vascular Access Teaching and Research. It's one of the groups that Professor Claire Rickard leads, and there's a whole host of people involved in that and closely linked here with HeIDI. And they've got a great site, and we do lots of education and research in the vascular access space. And on that site, if you go to that, there is often the most recent literature, studies published, if you want anything vascular access related, and they'll have summaries of some of those publications as well, and some teachings and learnings. So out of that particular study, looking at what was important to the patients is, what is it that they need to do to ensure the safety and efficacy of their device when they're at home, looking after that, this new device that they're having to manage. How do they prevent complications and discomfort, and having that confidence and skill to know how to maintain that, and that psychological impact and effect as well, as well. And that they want clear and concise information so that they've got a resource to go back to, know who to contact, and that's those sorts of things were really important, to know who to contact, etc. So on the within the AVATAR site, but there's a lot of literature and resources and support on the New South Wales Cancer Institute site, or EQIV, and these are some examples of these sort of patent literature, and we've got these linked in AVATAR as well. So you can go through either site, but looking at how are they inserted, treatment through the devices and what to do with them. So great literature within that. This is an example of what that covers, and this is really important for the patients in that it tells them what is a PIC, what does it mean. It's got a picture and an image so that they can see what it's meant to look like, so they have an understanding. If it's not looking like that, then maybe there's something not quite right. And an image to me is, encompasses a whole heap of things. If they can't, maybe read the literature, then at least they can visually see. It also tells them, about what's going to happen when it's being put in, when their device was put in, when the dressing needs to be changed next, how to care for it, what can they do in their activities of daily living, what things do they have to avoid, can they not do their sport or their or whatever during that period of time. And some of those common questions about, what happens in between, what do they have to do with that. But really importantly as well, if something does go wrong, what's an emergency? When do they need to, how quickly do they need to access medical help, or what can wait till the morning and it's not such an urgent thing but needs to be addressed pretty soon thereafter, and provides them that resource in a written format. And these things, are really vital to ensure the success of the HITH program, that the patients are, able to manage their devices and confident with that. Some of the other optimization outcomes, things as, technological advances like, antimicrobial coated catheters. And Buetti had an article in 2022 around the updates on, preventing bloodstream infections in acute care hospitals. And one of the components of that in the summary is there on the Avatar site to look at around what impregnated catheters for antimicrobial impregnated catheters, coated catheters. And, there is high-level evidence to say it demonstrates that it does reduce infection risk. There's only moderate-level evidence for pediatrics. But, the guidelines, suggest that, if they can be used or advised to be used as an additional strategy, particularly if hospitals have increased CLABSI rates. At the moment, nationally in Australia, we have an increased CLABSI rate. So these are the sorts of things that people can use as an additional option. We certainly use them routinely in our intensive care environment and in some of the longer-term catheter areas, not so much maybe in the HITH environment where it might be short-term, but the things to be looked at are, consider individual patient characteristics and needs and requirements. It may be that a particular patient that has recurrent CLABSI or difficult access may benefit from these as well. Or they may have things like a prosthetic heart valve, and therefore they're at a greater risk. Other things are like ultrasound-guided placement, and that's fairly routine here in the hospital when we're administering or inserting these devices. That they're generally done under ultrasound guidance, either in intensive care or the imaging department. That study there by Sorgel talks about that, and the fact that it's really quite standard practice that they're done under ultrasound guidance. There's a systematic review that was done in pediatrics around selection and device, which talks about that there is some evidence around ultrasound guidance, but there probably needs to be some more RCTs and things around some of the neonates and cardiac patients and those with difficult access. But everybody, I think it's pretty much of a no-brainer that ultrasound guidance is important. We're doing a lot more of that with peripheral access these days throughout the hospital and across the country. And And we're also, as I started to say before, the HITH nurses are actually doing ultrasound guided in the home as well for midlines when required as well. So in conclusion, they are critical devices. We need to, if we're going to be giving antibiotics then in the home, then we need to be able to have a device that's suitable for each individual patient in each individual situation, that's safe and it lasts the duration of the therapy with limited complications, and improves that patient's experience. There's one of the things that we do need to consider is how safe is giving long-term IV antibiotics, and where there's non-inferiority of antibiotics, when should we be switching to oral, and how quickly could we be doing that to minimise the number of patients that require long-term antibiotics but in the home environment. So there's always that balance, and if we don't need to be doing it, then these are still at a significant risk to the patients having these devices. So if we can get people to oral as soon as possible, then all the better. And so that article there by Sarah Browning talks about that in that study. And I'll just leave you with some of the top publications in OPAT in 2022, a summary overview if you're interested in looking at that. And I'll leave Bin to talk about the complications. So thank you.